All right, welcome to this review. We're going to talk about everything cardiac. I'm going to try and keep this relatively short, but there are a lot of slides and a lot of material to get into. Um, okay, first let's talk about the ECG and dysrhythmias. As you know, the ECG is the electrical map of the heart, and this is a list of things that it can show you. Definitely know this list. So it can show you the size of the heart, orientation of the heart, rhythm and rate disturbances, the ischemia, injury, or infarction. And we're going to go like really deep into that, as well as electrolyte abnormalities like hypokalemia, hyperkalemia can change your T waves, as well as drug toxicity, sort of the same mechanism, at least sometimes, as the electrolytes. Okay, conduction of the heart. So you start with the sinoatrial node, and that conducts between 60 to 100 at rest. Like obviously, if you're working out, then you can get above that, but that's kind of the average rate at rest. And then it goes through the internodal pathways to the AV node, which slows that rate a little bit before it hits your ventricles, so that your atria can contract fully and get all of the blood into the ventricles. And then you have your bundle of His, and then your these are the bundle branches, and then you have the Purkinje fibers, which send those electrical signals from the endocardium to the epicardium. So these are pacemaker cells, the ones that are in the AV and sinoatrial node. And then the ones that are like in the bundle of His, those are a special kind of conduction cell. And then every other cell in your heart is considered a myocardial cell. So when we're talking about um, the action potentials, we're going to be talking about what happens in the nodal cells in the AV and SA node, and then we're also going to talk about what happens just in all of your myocardial cells. And they're two different processes. Okay, so what does the ECG show you? So really important to not get confused between the waves of the ECG and the action potential, because she has both and they can be confusing. But hopefully by the end of this review, it won't be as confusing. So what does this show you? So the P wave is the atrial depolarization. Right, so that's the SA node going to the AV node. Your QRS complex is your ventricular depolarization, and it makes sense that it's much larger because it's a larger muscle than your atria. And then the T wave is your ventricular repolarization, and your U wave usually don't see that, but that's your Purkinje repolarization. So if you have repolarization, your repolarization of your atria are does occur, but it happens in the middle of your QRS, and so it's hidden. So that's why you don't see it. And this is the same mechanism we're going to talk later about, like junctional rhythms. And one of the definitions of a junctional rhythm is that either it does not have a P wave or the P wave is really close to the QRS complex. And that happens for the same reason. Like there's still a P wave because the atria do contract, but they just contract because it's starting from the AV node. It goes in both directions at the same time to your ventricles and to your atria. And so normally the QRS just masks the P wave, or if it makes it to the atria a split second before it makes it to the ventricles, then you'll see that P wave, but it's really close to the ventricles. Okay, so you'll want to know these intervals. So PR interval is 0.12 to zero point 0.2 seconds, so that's 3 to 5 little boxes. And then your QRS complex is you want that to be less than 0.10. Some rhythms have like a wide QRS, which means it's taking longer for the ventricles to depolarize and contract. Um, and that's greater than this. Usually it's greater than 0.12. And then your QTC is this whole thing. So that's important. Like down here it mentions um, that you're this puts you at a risk for deadly dysrhythmias, and essentially it makes the time when your action potentials are prone to they're weak to like repolarize to have what's the word to have like the repolarization quickly. We're going to talk about this. It makes it longer And so you're more likely to get that like PVC, and then the PVC happens on top of the T wave. The R on T phenomenon is what it's called. And then that causes your heart to just go crazy and it causes that torsades. Definitely know what torsades looks like. We'll talk about it. So, a important caveat is normally when you're looking at an ECG, that's telling you what the heart is doing. However, there are rare cases of pulseless electrical activity where you don't have a pulse, but you do see electrical activity. Um, and so you just got to watch out for this. Okay. Like if you see electrical activity, make sure you're still feeling for a pulse. It's important to do both of those things. Okay, so different terms to know. Automaticity is the ability to depolarize spontaneously. So only the nodal cells have this ability in the pacemaker. And then rhythmicity is it's regular. So it happens at regular intervals. And then refractoriness, and this is kind of what I was trying to say earlier, is that there's your cell does not want to depolarize when it's in the middle of repolarizing. However, there are certain parts of the action potential that are weak to depolarization when it's in the middle of repolarizing. Okay, so this is what we're talking about. So you have this, and this is a myocardial action potential. So this is not your nodal cells. It's not the SA node, it's not the AV node. It's not the Purkinje fibers, any of those. It's the rest of the cells in your heart. And they all depolarize, and that's why your whole heart can contract, right? So 4 is resting. This is just typical. The sodium's going out, potassium is coming in. And then you get a sodium influx. So sodium is positive, which means that you go from a negative value and you hit the threshold and then you go up to a more positive value. And then you have this one, which is potassium starts to go out, and that's why, okay, so you're losing positive, it gets a little bit more negative, and then calcium comes in, keeps it positive, and then eventually your potassium does continues to go out and calcium stops coming in and then you get that repolarization again. It becomes negative. Okay, so this is the nodal cells. This is your SA node, your AV node. And this is what makes them have that automaticity is because it's constantly having that influx of sodium that makes it hit that threshold at regular intervals. So the sodium comes in and then that hits the threshold and that causes calcium to come in. And then you have the outflux of potassium, which restores it again. Okay, so refractory periods, this is kind of what we were talking about earlier. So you have and I also put this is the action potential next to um, your ECG, QRS and T wave. So you can kind of see how they're happening at the same time. Um, so early in the three and from the three to like late three to the early four, you have a vulnerable period where if you get another impulse, it can cause an arrhythmia. So you can see if you have a wide QT interval, that period of weakness is enlarged. And so you're more likely to get those weird arrhythmias. Okay. Um, Pretty straightforward. So if you have increased slope, it'll happen faster. You'll have tachycardia. Decreased slope, you'll have bradycardia or escape rhythms where like your AV node won't even, it'll take so long that your AV node's like, okay, I need to kick in. And then it's starting to regulate your rhythm. So that's like one of the escape rhythms. Um, and then your reentry circuits, which is like things, the depolarization happens in like these circles. It can happen with ischemia where you have this piece of dead tissue, and so instead of the electrical signal, instead of going in a straight line, it hits the dead tissue, kind of goes around it, and then it starts like doing this circle thing, and then you can get these ectopic beats. Okay, so the vectors, um, know that there's some it talks about it a little more here. So you have a 12 lead AKG, and so you're putting like the 10 stickers on the person and it makes 12 leads. She doesn't go into it super in depth. And I've like looked into all the reasons why and the math and it gets like very complicated very fast. But just know that as an electrical signal with these bipolars, as it goes towards one of the leads that's positive, it'll make a positive spike on the ECG. And then you have like this MCL, which it's one of the ones where it just has like it mathematically creates a positive lead in the center of the chest. Anyways, it's very complicated. I would just make this one of the things that you look at really quickly before you go into the test, um, and just memorize it like that. Or if you want to look into it, you can too. Okay. Yep. So hopefully you know all this, what the small box represents, what the large box represents, and then just how to count. Right. She has her 300 way. If that works for you, do it. You can count the QRS complexes in that amount of time. Um, just make sure that your estimation is like, if you're in between beats or whatever, that you're also estimating in that way because it is an estimation. So count with in the 6 seconds, which would be the 30 boxes, and then multiply by 10. Okay. All right, so we're going to talk about different ECG and the rhythm strips. So when you're looking at it, you want to look at a few different things, right? You want to look at what's the difference between what's your PR interval? What's the distance between your P wave and your QRS complex? Is this a fast rhythm? Is it a slow rhythm? Um, do I see a wave that looks really abnormal? Could it be a PVC? So we're going to talk about them. Okay, so normal sinus rhythm, right? Sinus bradycardia, so it looks normal, but you also want to count how many there are. Okay, then you have sinus tachy. So sinus tachy, right, is between 100 and 150 beats. And then you have atrial tachycardia, which is greater than 150 and to 180, and then greater than 180 would be supraventricular tachycardia. And specifically with supraventricular tachycardia, you're not going to really see the T or P waves. You're pretty much just going to see QRS complexes because it's happening so fast. And then this is an important part. Just basic principle with all of Renee's tests is don't make them sicker than they are. So that means like if they have 100 and if they're at 150 beats exactly, it's not atrial tachycardia, it's sinus tachycardia. So you make it the lower one. They're at 180, it's atrial tachycardia. Okay, so atrial flutter. So this is the re-entry in the atria. So you get those off P like continuous P wave looking things, right? Because it's depolarizing over and over again in your atria. And so you'll see this flutter um, signal. And the big way I remember at least to tell the difference between atrial flutter and AFib is I think fib is like lying. So it's inconsistent. So atrial flutter is consistent. So you have these consistent QRS complexes. But when you come to AFib, these are not consistent. It's fibbing, is the way I think of it. Um, and so this also has F waves. Both Fs, fib and flutter, have F waves. Okay, so now we come to you have PAC, PJC, and a PVC. So a PAC is a premature atrial contraction. So if the atria are contracting, then you know you need to have a P wave. So that is like one of the biggest differences between a PAC and a PJC because atrias contracting require a P wave. So here you have your weird looking P wave and you have a premature or an early um, contraction. And then PJC is premature junctional contraction, and a junction node is another name for your AV node. So junction AV, you're thinking ventricles. It's either not going to have a P wave, or the P wave is super close to your QRS complex for the reason that I explained earlier. Oh, and there's the PJC. Yep, so you see it doesn't have a P wave here. But it's sinus rhythm other than that. You see the P waves for the rest of them. So it's not a junctional rhythm. It's still um, you can see all these P waves. It's still a normal sinus rhythm, but it just has a premature junctional contraction. No P wave. This is the junctional rhythm, right? We already talked about this earlier. And junctional rhythm, because it's being monitored or released by the the AV node regulates at 40 to 60 beats per minute. And so it'll be less than 60 if it's junctional rhythm. If it's greater than 60, it'll be accelerated junctional rhythm because that's an abnormally fast rate for the AV node to automate. And then, like I said, no P wave or P wave that's super close because it's depolarizing atria and ventricles at the same time. Okay, so premature ventricular contractions, you have this super wide, weird looking QRS thing. So QRS, ventricular contraction. Um, and yeah, and you also want to know whether it's unifocal or multifocal. So unifocal is that the long portion of the QRS complex is in the same direction if it's unifocal, and then it'll be in different directions if it's multifocal. Okay. All right, so then you have VTAC, it's long waves, and this is not perfusing, right? So you will feel their pulse too. Just because they have electrical activity doesn't mean they'll have this nice pulse. And this is a shockable rhythm, fib, shockable, and then asystole, you do not shock this. It's not going to work. Okay, so getting into the blocks, this is the way that I remember blocks. If this is helpful for you, you can remember it. If it's not, then don't remember it. But I think of um, as you get into higher degrees of blocks, that is the worse, you get a worse friend in the P wave. So I think of the P wave on top of this cliff holding on to the QRS complex, and the first degree is you're going to have a better friend with your P wave. And then as you get towards the third degree, you have a worse friend with their P wave because they drop the QRS every time. So, um, so first degree heart block, your friend is your P wave is holding on to the QRS, and they're a great friend because they never let go. They may be stretched out, their arm is fully stretched out, but they're holding onto the QRS complex, like their life depends on it because it does. And and they never let go, so they never drop the QRS complex. That is a first degree heart block. Second degree heart block is longer drop, right? So they're holding on to the P wave's holding onto the QRS complex, and they're trying and they're struggling, but their arm stretches, and then despite their efforts, eventually they drop the QRS complex. But they tried. They gave it an effort at least. And even when it got harder, they just stretched to keep hold of them. And then you have the second degree type 2, which is they're holding on to their friend, but they don't even stretch to hold on to them. Like the minute it gets hard, they just let them go. So you never have an increased PR interval. And then the third degree heart block is there's no correlation between P waves and the QRS complexes whatsoever. They don't even hold on to the friend. They just drop off the cliff and they're like, oh well. So the worst friend of them all. And then if you're looking at this rhythm, you see that the P waves, sometimes they're hidden by the QRS complex, but they're consistent at equal intervals. And the same thing with the R waves of the QRS complexes. Okay. So cardiac anatomy, about two fists put together. Left ventricle is in the back. It's the bigger, stronger muscle wall. You usually don't have cardiac cancer because cardiac cells don't usually divide. I don't think they ever divide. I don't know. I could be wrong about that. Okay. Um, so atrial kick, I won't go over all the things on these slides, but atrial kick, last 20% is pumped out. So if you have like AFib or something where it's not really contracting, then you lose a lot of that blood flow, and it can put you at risk for things like clots, which right, foreshadowing, we're going to talk about TEEs, which are going to put the camera down your throat, and you're going to be able to see if there's a clot. And AFib is something that can put you at risk for that because the blood is not flowing, and when blood doesn't flow, it clots. Yeah, okay. So talking about your heart valves, we'll talk about them more in a minute. You have your papillary muscles and the chordae tendineae, which hold on to your AV valves, so your tricuspid and your bicuspid or your mitral, and they prevent the valves from everting, so they prevent regurgitation. Um, and they don't pull on the valves to open them. The valves open with pressure differences. but they just prevent when the heart contracts, they prevent the blood from flowing back. Um, okay. Okay, so here are the different spaces. I would know that. So heart sounds, you have that's the beginning of systole. So your ventricle's starting to contract and it doesn't want to go back into the atria. So your AV valves close, and then your aortic and pulmonic valves open, and then on diastole they close again. So that'll be S2. So S1 then S2. S3 is an early diastolic sound, where the blood is rushing into your ventricle, uh, and this is right after S2. And if your ventricle is really dilated, then you hear a lot of sloshing. And then with S4, this happens at the end of diastole, so right before S1, and you will have that atrial kick. It tries to push in the last little bit of blood, but if you have a stiff ventricular wall, then it'll also make a rushing sound. So any murmur is just a sound of blood hitting itself or hitting a valve or hitting a ventricle. Blood's hitting something. And then a bruit would be if you're hearing that blood rush out somewhere outside of the heart. Okay, I think we talked about this. So you can use these mnemonics. I think it's just easier if you just understand what's going on inside of the heart. Um, so think in systole, your ventricle is contracting. And so where is that blood going? It's either going through to your aorta, and if your aortic valve is stiff, you're going to hear that blood hitting that aortic valve. Or we don't want this, of course. It's going back into your atrium through the mitral valve. And so you're going to hear that regurgitation as well. And that's happening when your heart contracts. Now, the opposite with diastolic, if during when your heart's resting, we don't want the blood to come from the aorta back into the ventricle, filling it up. That would be aortic regurgitation. And we also want that blood to be able to flow well from the atrium into the ventricle. So just imagine with like stenotic valves, if you're blowing out through your mouth, if you have an open mouth and you blow out, you're not going to hear it as much as if you have like, if you're puckered and you go, like you're going to hear that more. And that's kind of what you're hearing with the murmur. And then when you grade it, so one is the faint and six is you don't even have to have a stethoscope. And then the murmurs begin, or sorry, the thrills begin happening at about 4 plus. So with cyanosis, decreased cardiac output, and where you'll see this, right? You'll see it in the nail beds or the lips and the earlobes with peripheral, and then with central, that's really bad. Um, and you're going to want to check this by looking at the mucous membranes, see if you can see any cyanosis there. Um, and then she has this question about like the hemoglobin. So the hemoglobin not being oxygenated is what looks blue from the outside of your body. And so if you have less hemoglobin, even though you're not receiving much oxygen, you won't look that blue because the hemoglobin is what makes you look blue. That makes sense. Okay, so JVD. So this is with um like edema, heart failure. Um, So if you measure in 3 centimeters above the sternal angle, you can see the jugular vein, then you know there's a lot of that right atrial pressure backing up into the veins because the heart's not able to pump out enough to the rest of the body. Um, right, so you see that with edema. Um, and then you have this abdomino-jugular reflex, where if you push down on the abdomen, you'll see the JVD rise, because you're increasing that like the pressure, but your heart's not able to pump out the blood, so it just backs up into the jugular vein. Okay, so pulse pressure, it's gonna be a really confusing concept. The way I remember it is that if you have your if your blood, the amount of blood that your heart can pump out, um, mainly determines your like systolic, and then your vasoconstriction or dilation is a lot of what determines your diastolic. And so, for example, here with the narrow PP, you have your low volume, you're not tamponade, heart failure, all of these things you're not pumping out very much. And so your systolic's not going to be very high. But your constrictory was how do I say this? Your veins are uh your sorry, your blood vessels are constricting as they should, is what I'm trying to say. And so that's why your diastolic will not necessarily be low. It'll be high, so you'll have a narrow pulse pressure because you're not pumping out very much, which is the systolic, but you're vasoconstricting as you should, which is the diastolic. And now the wide pulse pressure is if you have that vasodilation, so your diastolic is going to drop, or if you have high output. So it's kind of like these two things. So output and vasoconstriction. Yeah, that's your diastolic and systolic. And then remember the MAP formula. If you have less than 65, you'll have poor organ perfusion. Um, okay. Okay, so if you have perfusion or venous problems, so if you're not getting enough blood, you're not getting nutrients. So you'll have like shiny skin. It's not like creating more skin, and your hair's not going to grow as it should. You'll have all of these symptoms of nutrients not reaching your extremities because it isn't. Um, and then with poor venous return, you'll get edema because the fluid is stuck there, it has nowhere to go. And eventually you'll have this brawny edema. Most of us have probably seen this with like elderly patients. It's just like these brown, scaly legs. Um, and venous insufficiency is what causes the brawny edema. And then anasarca, right, is just this generalized edema. Okay. So sudden cardiac death, more common in men. This is usually due to VTAC or VFib or asystole. Usually happens outside the hospital. Um, and estrogen protects women, but as they get older and they're not producing as much estrogen, then that risk gap narrows. And they're more likely to experience it at the same rates that men do. Okay, so what do you want to do, right? Give them CPR. Therapeutic hypothermia protects the brain function because the brain uses so much oxygen. The cells will die faster than other parts of the body. Okay, artery disease. So the vessels begin to narrow with plaque, and you'll see those symptoms. We'll talk about these symptoms like angina as the lumen narrows to greater than, if the lumen is narrowed by greater than 75%. Okay, these numbers I would also just look at right before you go in to take the test. Is a review from Patho. And the CRP is just this marker that shows general inflammation. It's highly sensitive, but not specific. It doesn't tell you where the inflammation is or what's going on. Okay, path of atherosclerosis. So it begins with the intima and then eventually can reach the media. Starts off fatty streaks we get when we're really young, and then it builds this fibrous plaque. It gets vascularized, and then it can break off, and you get like clotting that happens too. It's just this giant mess, and it can occlude arteries. And then when the arteries occluded, then you don't get as much oxygen. So this is what's happening here with these anginas. So stable angina, it's predictable. So if you are like have occluded vessels and you start going for a run, then your heart needs more oxygen, but it can't get it like it needs it. And so then you start getting that pain. It's relieved by stopping the exercise or nitroglycerin, which causes vasodilation, more blood flow. And stable angina is essentially just even more occlusion. So even when you rest, you're not getting, it doesn't relieve it. Variant angina is a coronary artery spasm, so not necessarily due to atherosclerosis. And then silent ischemia is you're having the issues, but you just don't manifest symptoms. So this is important. Women and diabetics show different symptoms than males. Um, like men often feel this like crushing pain on their chest and it radiates to the arm, but these populations often describe it a little differently. Arm heaviness, And these are very generic symptoms. So, it's less likely for these populations to get a quick diagnosis of uh, like a heart attack because they don't manifest it in a very obvious way. So that's why it's important to just be aware of who your population is and um, run all the tests that you need to. Okay. So managing angina, we talked about this. Just make it easier on your heart to get oxygen, modify your diet, might be placed on telemetry. So this is our different um, forms of necrosis. So you have ischemia, which is T wave inversion. You have injury, which is ST segment elevation, and infarction, which is this Q wave that is greater than a third of the total QR distance. So this looks like it's about a half, so it's greater than a third. And STEMI is essentially a STEMI with no ST elevation, but you have all of the other labs and symptoms that would go along with a STEMI. Um, okay, so these are different treatments for an MI. Um, so TPA, this you'd want to use quickly, and it essentially is a drug that breaks up the clot. Um, and then PCI, percutaneous coronary intervention. This is the one where you can put in a stent. We'll talk about this, I think, in a future slides. And then the cabbage, right, is where you do the graft. So instead of like breaking the clot itself, you just bypass it to give the heart oxygen a different way. And then the IABP is to help support the heart and increase coronary perfusion as well as systemic perfusion. And I think we'll talk about that too. Okay, heart failure. So you have these compensatory mechanisms because your heart is not pumping out enough. And so your body is trying to do what it can to get more blood out. So it'll trying to get more blood more blood into the heart. It'll try to increase the muscle hypertrophy. Um, but eventually all of these things that it does end up being maladaptive. Right? Because if your heart hypertrophizes, if it goes through hypertrophy, then it can't fill as much, so it can't pump out as much. So eventually these things cause issues. And if your heart is not pumping out, it doesn't get perfusion, the rest of your body. And you'll get acidosis, right? Because you're going into anaerobic metabolism. You're getting increased respiratory rate because your body senses it's not getting the oxygen it needs, so it tries to bring in more oxygen through your lungs. And then if you get backward failure, then the blood is backing up, and you'll see all these edematous symptoms. So pulmonary edema, you have crackles, which is a result of the pulmonary edema. You'll have hepatomegaly, which is also like edema in those vessels, and jugular venous dissension. You just see that blood backing up. Okay, and then this classification, fairly straightforward. She gives you a scenario on the test. It should be pretty simple. Like if it's like you feel like you're not able to go brush your teeth, then that would be a marked limitation. If you're not able to like run out to the mailbox, that would be a mild limitation. Or you're like not able to go on a run or whatever. And then if you have that difficulty at rest, then that's severe. Okay, so cardiac tamponade is when your cardiac sac fills with fluid. It can be multiple causes. So if you have an MI and that dead tissue ruptures, then you can get blood filling your sac. Pericarditis, that would be inflammation causes fluid to fill the sac, and so it's a big issue. Beck's triad, super important. You'll see the JVD, right? Because the fluid's backing up, you're not able to pump out. You hear muffled heart sounds, which makes sense because there's so much fluid, it's interrupting the sound waves, and you'll see hypotension for the same reason you're not pumping out enough. So you'll do pericardiocentesis, you take the needle, go up, and then pull it out of the sac. I mean, we won't do that as nurses, but you'll want to know that that's what's going to be done. Okay, biomarkers. So sometimes we trend these, sometimes you just get an immediate number. Um, so you have I and T, which are very similar. I is a little more specific for cardiac injury. You'll want to know these numbers of when it peaks and everything. High sensitivity, if you're working in an ER, they're going to get this number a lot because it can tell you pretty quickly, um, like almost as quickly as myoglobin. And then if you're trending the troponins and your troponin is decreasing, then you know that your heart is no longer being actively damaged. So CKMB, this is important mainly because it can tell you if there's a reinfarction because it decreases in levels faster than troponin. So troponin will stay elevated longer, so you won't be able to tell from the troponins if you get a re-injury, but your CKMB you will be able to. Okay, and then we have the myoglobin. It's the fastest, but it's also the least specific to the heart because all of your muscles have um, myoglobin, so it could be damaged to anything. So you'll want to use other um, manifestations to make sure that an increase in myoglobin really is referring to the heart, not something else. So BNP, if your ventricles are stretching because of volume, then your brain thinks that you have too much blood. And so when your brain thinks you have too much blood, it says P. So natriuretic peptide, uresis, P. And so this can help us differentiate between fluid in the lungs or lung issues that are a result of the heart or a result of something else. And so if someone has a high BNP, then you know that their heart is too full of blood, it's not able to pump out enough, and so that fluid is backing up into the lungs. Um, but if they don't have a high BNP, it could be something else. So here are the different zones. And a caveat or an exception to this is kidney failure. So BNP is excreted in the kidneys. And then obviously, if you're holding on to fluid because you have in kidney failure, then you'll have a high BNP just because you have more fluid. So, okay. So diagnostics, I think we talked about this already. So here are the different leads. So the lateral ones go from side to side lateral. And then the inferior has two that are on the bottom. So inferior. And then you have the other one, which is the anterior. And then you don't pay attention to the AVR. And then here's the different arteries. So you have the circumflex coronary artery, which is the lateral wall. Um, so think like circumflex, something like circumference goes around the edges. So circumflex, right coronary artery is the inferior, and then left anterior descending artery is the anterior. And you can remember this too, because we talked earlier that the like the front of the heart is the right side of the heart. So that's kind of like the inferior kind of. Anyways, just remember that. Okay, Holter monitoring. So you're not going to do this with someone in critical condition, but if someone feels like they're experiencing like the heart skipping a beat or they have they're fainting or something like that, and they come in and they're not manifesting anything in the moment, they'll say, okay, well, we still believe you, but we're going to give you this Holter monitor that just has a few leads, and and this will record the data for 1 to 4 weeks, and then come back and we'll see what's going on. Chest X-ray. Pretty straightforward. This isn't going to tell you about anything about the volume of ejection fraction or anything like that. This is purely size. This is purely structures of the chest. Echocardiography, so the external one is just like a giant ultrasound essentially on the outside of the heart. And then the TEE is the more invasive one. TEE is going to be more like accurate. It's going to tell you more about what's going on inside the heart. And this is the one that tells you about clots, if they have a clot in their left atrium. Okay, stress testing. Essentially, it's like trying to give someone that like angina, right? So it's making the heart require more oxygen to see if they are getting enough oxygen, sort of. Okay, cardiac catheterization. So not only is this used for placing stents, but it's also used to visualize what's going on. So people are going to be given contrast, and they're essentially going to be have like a continuous CT scan sort of thing, and you're going to be able to see what's going on inside the heart. Um, so yeah, okay. The TCA, this is the balloon angioplasty where they inflate the balloon to squish the plaque against the sides of the heart, and usually a stent is placed at the same time. Um, so a drug-eluting stent, the stent's put in, and that stent is coated in a medication that will attempt to prevent restenosis. And risks for anything, anytime you like touch the heart or stick something in the heart, you're placing it at a risk for arrhythmias. Um, and then also renal injury. This is why you want to give them the IV fluids. Um, and that's kind of your main priority as a PACU nurse is you want to make sure that this person is getting the fluids they need so that they don't have the renal injury from the contrast. And you also want to monitor for bleeding, which can be caused by bending. So um, you're checking their wound site. You're looking at their vitals, right? If they have tachycardia, that could be an indication that they're bleeding, low blood pressure, those kind of things. And usually you want to check the groin because they use the femoral artery usually to go up to do these procedures. Okay, the IABP, so this is the intra-aortic balloon pump. This is to support the heart. So um, it deflates so that the heart can pump out the blood. And then when it inflates, it keeps this open so that this blood can go in and you have the coronary arteries that stem here at the base of the aorta, and they can help keeping this open helps those vessels to stay open and they can receive blood. Okay. Oh, and things to monitor, limb ischemia, especially in your legs because they use the femoral artery to put this in. Dysrhythmias, like I said, anytime you put something near or touch the heart, and catheter migration, right, if it moves. Okay, cabbage. So this is when you take that vessel from somewhere else in the body and you use it to bypass a clot or an infarct. Okay. So yeah, just watch for vital signs. What's their heart rate doing? Monitor the preload and afterload. You can tell those things with, blood pressure and other things like that. Um, and, bleeding, tamponade, temperature. So look for those vital signs. See what's going on. So yeah, so just be aware of these other tests. I think she talked about them super briefly in class. I would highly doubt that TAVR or carotid endarterectomy are going to be on the test. I don't know what those are. So I think she mainly talks about the top ones. So pacemakers, fibrinolytics, those drugs that break open the clots, cardioversion when you have those strain not healthy electrical rhythms that you need to be restarted, ablation where you burn those weird reentry sites. Um, for sure know those ones. Okay. All right, we're gonna do a quiz. So if you want to have time to think, go ahead and pause it after the question is asked. Which part of the ECG represents ventricular depolarization? It's the QRS complex, right? PR interval of 0.28 seconds. So that's a long PR interval. And let's say that you have every QRS complex. That's first degree heart block, right? It's the best friend where he's like stretched, but he never lets go. Okay. During which phase of the myocardial action potential does calcium enter the cell, causing contraction? That'll be phase 2, right? It keeps it depolarized momentarily. During the absolute refractory period, the cardiac cell, blank, it can't be depolarized. Can't respond to any stimulus. Where is atrial repolarization seen on the ECG? Trick question, it's not seen because it's lost in the QRS complex. What is the main function of the AV node? Is to delay the conduction, right? To allow those atria to contract. Wait. Okay, I think we had that question twice. Okay, which ventricle forms most of the anterior surface of the heart? That would be the right side, the right ventricle. During ventricular diastole, which valves are open? So this is when the ventricles are being filled. So they're being filled from the mitral and tricuspid. What causes cardiac valves to open and close? So it's pressure differences. It's not the papillary muscles. Those are what prevent the valves from everting or inverting when they close. But the pressure is what causes the valves to open and close. Which heart sound is the result of blood hitting blood in a stiff, non-compliant ventricle? So this will be S4, right? So S3 is the blood kind of hitting blood as it rushes into this is if you have a lot of blood. It's rushing into the ventricle at the beginning of diastole, and then S4 is at the end when you have that atrial contraction. And this is if the ventricle is stiff. Okay, a murmur that occurs between S2 and S1 would be classified as, so between S1 and S2 is systole, right? So this would be a diastolic murmur. Um, if you remember what valves close with S1 and what valves close with S2, and remember that between like S1 signals beginning of systole. Um, so that will help you to remember these ones. Central cyanosis is best assessed by examining the mucous membranes. Jugular venous distension greater than 3 centimeters above the sternal angle suggests heart failure. A narrowed pulse pressure most likely indicates. So narrowed pulse pressure means that your diastolic, right, or your vasoconstriction is doing just fine, but you're having less output, which is mainly controls your systolic. So that'd be hypovolemia, dehydration, those kinds of things. Wide pulse pressure might be the opposite. So vasodilation is what's going to cause this. Bronchial edema results from long-term edema, which causes that scar tissue. Which type of edema is described as generalized swelling throughout the body? Anasarca lycoparka. Misspelled that. Okay. Why is CKMB sometimes used to identify reinfarction? So remember, troponin stays elevated for a while. CKMB will fall back to normal pretty quick. And so this can tell you if there's a new rise. What is the earliest biomarker to rise after myocardial injury? Myoglobin. So it's the quickest, but it's also not very specific. High sensitivity troponin is 1 to 3 hours. What ECG change indicates myocardial ischemia? So not injury or infarct. Ischemia is going to be these inverted T waves. What ECG change indicates infarction? Okay. The significant Q wave, at least a third of the height of the total QRS. Which ECG leads reflect the inferior wall of the heart, and which artery is usually involved? So it's 2, 3, and AVF. So those bottom ones. Oh, I guess for you guys it'd be like this. And then the right coronary artery. What is the gold standard test for diagnosing coronary artery disease? Cardiac catheterization. What complication is most life-threatening after a stent placement? Perforation. So if the stent um, breaks through the heart, the vessel, then it starts bleeding, and as you can imagine, that'd be disaster. What are the most common complications after CABG surgery? So these are the ones we were talking about. Remember to check those vital signs. Why might a patient have a significant Q wave weeks after an MI but a normal troponin level? So thinking about this, what does a Q wave represent? And then what do troponin levels represent? So if a Q wave represents infarct, aka dead tissue, and troponin level indicates damage to the tissue, then this means that the tissue was damaged and now it's dead, but is no longer being actively damaged. So that's an old infarct. So explain how PTCA and CABG both restore perfusion but differ in approach. So the PTCA goes in, opens up the vessel specifically, and then the CABG bypasses the vessel. Name 3 modifiable risk factors for CAD. These are all the basic ones we talk about a lot. Patient has stable angina triggered by exertion. Which intervention is most appropriate? So yeah, rest, nitroglycerin. Difference between stable and unstable angina. So, um, unstable can occur at rest, right? It's not provoked, so it's not predictable. Um, and it could signal the beginning of an infarction. Okay, so looking at these, where's the MI? So, um, so these ones look really long, and we might be, tempted to say, oh, this looks kind of like a Q wave. The Q wave goes down really far, but you have this peak here, so they must have either super insignificant Q wave, and then here's the R, and then this is the S wave. So S wave doesn't have anything to do with, you don't have like a significant S wave. You do have an elevated S wave, so here's your ST elevation here, and then you also have some ST elevation in these different ones. So see it pretty consistently there on this lateral one. It's because you can see it right there. ST segment elevation, ST segment elevation. It's arguable up here. However, you have it over here, over here. So all of the lateral ones have the ST segment elevation. And even if you see something a little interesting in another box, remember that's a preponderance of evidence, which means for Dr. Beckstrand that more than half of those leads need to show that um, dysrhythmia. Okay, identify the rhythm. So here we either have, I think we have this P wave, it's super close to the QRS complex. So this must be monitored by the AV node. So it's some kind of junctional rhythm. Then you'd want to count these. Is it less than 60? Is it greater than 60? So it's greater than 60, it'll be accelerated junctional rhythm. What would cause this rhythm? So identify the rhythm. It's not lying to me because it's consistent, so it's not a fib. It must be a flutter. And then what causes that? It's re-entry in the atria. So you have those electrical rhythms that are going around and around and essentially mimicking an atrial contraction, which is your P wave. So you see all of these things, but they call them F waves. They're not true P waves. Okay, so these ones you can recognize right off the bat. Right? This looks really funky. It's going to be a PVC. The question is it a run? Is it unifocal? Is it multifocal? So these are all going in the same, they're uniform. So it's unifocal, and they're in couplets. Okay. Well, hopefully that helps and wasn't too long for you, but good luck with the test, and let me know if you have any questions.